I thank on behalf of the Session 2 panel, thank the American Cancer Society and the Institute of Medicine for really organizing such an outstanding group of people to participate in this meeting. And it's really, I think, an honor for all of us to be a part of this meeting. The Session 2 is discussing the considerations of patient-family engagement in assessing the pediatric pipeline. From an NCI perspective, which is where I work, this involvement of patient families in the prioritization process is taken as a given. In the NCTN cooperative groups, like the Children's Oncology Group, the patient-family representatives are members of the disease committees. When we look at our data safety monitoring committees, again, patient-family members. In our steering committees, the Pediatric Leukemia Steering Committee, the Solid Tumor Steering Committee, the Brain Malignancy Steering Committee, all of these have patient-family representatives. So it's a given that, that these patient-family engagement is a key part of the prioritization process for the pediatric pipeline. Before we proceed with the presentations and the panel discussion, I want to make 3 points to set the stage for our panel discussion. The first point is that collaboration continues to be central. Pediatric oncology is a discipline that was born of collaboration. Looking back to our founders 6 decades ago, from the beginning, it was a collaborative effort because of the recognition that to do clinical trials, you had to get multiple institutions to work together. And so really it's in our blood that it's collaborative. And today, this collaboration is more important than ever before with our continuing subsetting, as was talked about in the first panel, of patient groups into smaller and smaller subsets. And so it's not hyperbolic to say that to reliably answer important questions of therapy for these clinically, genomically defined patient populations, it requires the population base of North America or Europe or, and sometimes both of those. And when I think over the last months of protocols, concepts that we've seen, Down syndrome, AML, FLT3-ITD, AML, acute promonocytic leukemia, Wnt pathway medulloblastoma, sonic hedgehog medulloblastoma. All of these are populations where we can do clinical trials, but it really does take North America to get enough patients to obtain meaningful answers. And one point to make is that there's no statistical shortcut that gets around this. There's no Bayesian magic wand that we can wave over a clinical trial, and then it's only a handful of patients that it takes to identify that this treatment is the preferred one over another one or over standard therapy. And I'll call to your attention, Ed Korn, Lisa McShane, Boris Friedland published an excellent article about statistical designs for small patient populations. And we use many of their methods in the work, in the clinical trials that we do. But even, using these methods for small populations, for these subset populations, it takes a collaborative effort. And so I think one point is it's really important to nurture the infrastructures, the collaborations that exist, and strengthen our ability to collaborate with partners in Europe and Asia and other places. The second point is the importance of focusing on survivorship. Greg Greenman pointed out that the place we really want to be is what's shown here is context A, where treatment may be for 6 months or a year or longer, but then there are decades of survival after that. And so that the time post-treatment is really much longer than the time on treatment. It's very different context than most of the regulatory approvals for adult indications where these are advanced disease in adults. The time on treatment is a substantial percentage of the expected life expectancy. So this just really points to the importance of survivorship, focusing on survivorship for prioritization of treatments, of questions of therapy. And so when we have new questions, new clinical trials, one of the first things we think about is what is the impact of the new therapy on survivorship? Will it address a critical issue of survivorship for the patient population, neurocognitive, cardiac, second cancers, et cetera? And then the final point to make, and it's particularly important to prioritization, is the issue of disease and population-centric prioritization versus agent-centric prioritization. What I'm talking about here is really illustrated here by two very distinctive questions. One question is, what's the best childhood cancer clinical trial that we could design for a given experimental agent? So get a group of experts in the room and say, here's our agent, here's what it targets, what's the best clinical trial? And the experts might come and say, oh, well, it's a trial for high-risk neuroblastoma. So that's one question. A very different question is to say, what's the most important question of therapy to be addressed for a given cancer patient population? And here would get the group of experts in the room and say, okay, we're thinking about high-risk neuroblastoma. What is most important for those children? What question of therapy is the key one for those children? And it's important to distinguish between these two for a couple of reasons. One is we can't do both. We can only, with high-risk neuroblastoma as an example, every probably 4 or 5 years we could do, again with a continent's worth of accrual, a definitive trial for high-risk neuroblastoma. And so we have to prioritize. And the second is, that these important legislative initiatives have focused on the first question as ways to incentivize or mandate pediatric clinical trials. And so we want to be thinking about, for a specific patient population, we want to have a new clinical trial and be thinking about issues like, what are the key factors associated with treatment failure for this population? What are the key short-term and long-term issues that diminish quality of life or quality of survivorship? And then, based on that, what are the most promising clinical research opportunities that we could explore for that patient population? Although this is not a solved issue, and I think it's really the people in this room, the academic researchers, the pharma, the patient family representatives, and the regulatory agencies that really need to come up with a solution for this. How can we take advantage of legislative opportunities for encouraging pediatric clinical trials while at the same time keeping the focus on what's the most important question of therapy for a specific patient population? So with that as kind of setting the context for this pediatric pipeline and some of the issues that we'll be discussing, it's my pleasure now to introduce Lillian Sung, who will be our first speaker for the presentation.